Okay, we'll be talking about status epilepticus. Okay, and status epilepticus is defined as prolonged single seizure or multiple episode of seizure lasting more than 30 minutes without regaining consciousness in between. Okay, this is status epilepticus. Okay, and this impending status epilepticus refer to any seizure lasting more than 5 minutes. Okay, so same thing. So if the seizure is more than 30 minutes and there is no gain of consciousness in between. Okay, and if the seizure lasting more than 5 minutes, then that is called as impending status epilepticus. Okay, now we have different type of status epilepticus. They are generalized convulsive status epilepticus. Next one is focal convulsive status epilepticus and absence seizures. Okay, absence seizures. So these are the different types of status epilepticus. Okay, and operational definition of ILEAE. Okay, so operational definition ILEAE 2015 define if the seizure lasting more than 5 minutes, that is also called as status epilepticus. Okay, so these are the questions. Now what are the etiology of the status epilepticus? There are different etiology of the status epilepticus. Among them, first one is CNS. Okay, and metabolic abnormalities, and the next one is head trauma. Next one is severe cerebrovascular accident. Okay, head trauma. Okay, trauma I have already mentioned. And we have drug toxicity over here. Okay, and drug withdrawal syndrome. And next one is inborn error of metabolism. Okay, in CNS we have meningitis, encephalitis. Okay, and intracranial abscess. Okay, intracranial abscess. So this is the thing. In metabolic we have sodium level, if there is hyponatremia, if there is hypokalemia, if there is hypocalcemia, if there is hypoglycemia. Okay, hypoglycemia. Next one is hepatic encephalopathy. So these are the metabolic cause for status epilepticus. And air trauma, that is also another cause, CVA. Next one is drug toxicity. Okay, and drug withdrawal syndrome like alcohol, benzodiazepine, and barbiturates. In pediatric case, there is no case of alcoholic history. Certain there are less in number, but sometimes that withdrawal syndrome also can cause status epilepticus. Okay, now let us talk furthermore about different types of status epilepticus. Okay, so the initial one is that is convulsive type of seizures. What are the seizures that are be seen in this status epilepticus? But another thing is, on the basis of treatment, we can define this status epilepticus on established and refractory status epilepticus. So if the patient is presented to us, okay, so we give first line of anti-epileptic drug, anti-seizure drug. Okay, anti-seizure medication. Then if the seizure exceed after giving single dose of benzodiazepine, then that is established status epilepticus. Here what happens, after giving benzodiazepine, single dose of benzodiazepine, the seizure exceeds, then that is established status epilepticus. Next one is refractory status epilepticus, which means if the status epilepticus after giving benzodiazepine and phenytoin. Okay, so if we give second line anti-epileptic drug, again the seizure is continuing, then that is called as refractory status epilepticus. And next one is, this is a refractory. Okay, refractory status epilepticus. Another one is supra-refractory status epilepticus. So this means status persists for more than 24 hours. If the seizure is persisting more than 24 hours, and then that is called as supra-refractory status epilepticus. Okay, so now we classify. Okay, okay, according to etiology. We have cryptogenic, symptomatic, hypocalcemia, hypomagnesemia. Okay, these are according to etiology. And so these are cryptogenic, symptomatic, in symptomatic we have acute symptomatic and remote symptomatic. Okay, now let us manage this case. Okay, so what is the pathophysiology of the status epilepticus? So same thing. Okay, so there are excitatory neurotransmitter and the inhibitory neurotransmitter. So this must be balanced. So if there is imbalance in between these two things, then what happens, there is seizure. Okay, so seizure prolongation of seizure is based on the etiology. Okay, these are the things we have to know about. Okay, now let us talk about management. Okay, in management we have to do three things. They are sterilization. Okay, sterilization, termination. Next one is find etiological factor. Okay, so patient is presenting to us. Okay, so now let us approach the same things. a patient is presented to us with seizure, okay, and abnormal body movement. Now what we have to do first, okay, so firstly we have to do sterilization. We have to do airway, breathing, and circulation, okay, and circulation. So these are the things. In airway we have to clear the airway. In breathing we have to assess the breathing better to intubate the child, okay. In circulation we have to open double bore cannula, okay, and so we have to look for GCS. If the GCS is less than 8, then we have to admit him to PICU, okay. Then after sterilization, then we will progress with termination of the seizure, okay. Termination of seizure, we can give firstly we can give benzodiazepine. In benzodiazepine we have 3 drugs. They are midazolam, diazepam, and lorazepam. Midazolam can be given in rectal, IV, IM, and nasal route, okay, and diazepam and lorazepam, okay, and established and refractory treatment. So we have to deal with that thing as well, okay. So in termination seizure we can give benzodiazepine, and then if the first line doesn't work, we can give second line antiepileptic drug, okay, that is phenytoin. But phenytoin should not be given mixed with dextrose, okay. Now if control, so if the seizure control, then we have to give maintenance dose. If not control, then we have to give second line drug, that is phenytoin, okay, and if phenytoin not happens, then we have to give other drug as well, okay. So now we can also give pyridoxine as well, okay. Sometimes we can give pyridoxine 500 mg once or twice vitamin B6, okay. This is also included in the treatment of the status epilepticus. Now how we investigate? So patient is presenting to us. Now we are doing sterilization. ABC we have already done ABC. Then now we are managing the cases, okay. So we are opening the cannula. So in the same cases we have to examine the patient. So we have to send for investigation. We have to give CBC, ABG, serum electrolyte, RBS, calcium, blood serum, blood culture, okay, blood culture, and septic screening, okay, and lumbar. And then these are the things we have to look for initially. So now if the patient is managed, then we have to move further, okay. So if the patient is managed, if the patient seizure is within control limit, then what happens? We can do lumbar puncture, ECG, okay, CT and MRI, and we can also do toxicology screening, okay. Sometimes toxicology poison also may cause these seizures, okay. Now with this we will move further, and if the cause is hypoglycemia, then we have to give dextrose. If the cause is hyponatremia, then we have to give 3% NaCl. If the cause is hypocalcemia, then we have to give calcium gluconate, okay. So according to cause we have to do the treatment, okay. So if the investigation come out and if something is low, then we can treat the electrolyte disorder, and if not, then we have to move further. We have to find the other cause, okay. So same thing I already mentioned, okay. We can do LFT, RFT, ABG, okay, anticonvulsant levels, okay, and magnesium, CBC, malarial parasite also we have to check for, okay. And we have already mentioned about established and refractory. Now lastly, so the chart form, how will manage the case, okay. So if there is acute seizure, then we have to look for, if the patient present to us, then we have to look for history examination and so wait is have to sort in the cause, okay. Then we have to do SS and maintain ABC, okay. Then we have to maintain ABC. We have to give oxygen, okay, maintain airway, breathing and circulation, establish IV line and blood glucose stimulation, okay. And after that, if the same thing happens, then we have to give IV diazepam, okay. This is the first line anti-epileptic drug. If this works, then we can give some maintenance dose. If not works, then we can give, okay, for 10 minutes if it continues, okay. If not, then we have to give IP phenytoin after 10 minutes, okay. After 10 minutes we can give phenytoin or phosphenytoin, okay. So this phosphenytoin is more comfortable drug, okay, more usable drug. And then if phenytoin also we given this drug, if not control, then we have to do IV. We give IV valproate, okay. If we give IV valproate, if the seizure controls, then we have to stop here. If not control, then again we have to move further, okay. So if not control, then we have to give IV levetiracetam, okay, levetiracetam, okay. So we can see same things, okay, IV levetiracetam, okay. If not, then we can give, if also not control, then we can give phenobarbital, okay, phenobarbital. So if this also not controlling the seizure, then what happens? We can do elective, okay, elective intubation, okay, mechanical ventilation. Okay, so lastly we can give midazolam infusion. Okay, midazolam infusion IV. Okay, we can use through IV route, and then we can give pentobarbital. Okay, pentobarbital coma. So we have to give pentobarbital and we have to induce the coma. So okay, so in this way we have to manage the seizure. Okay, so what is the dose of midazolam? Okay, the dose of midazolam is IV. If you can give through IV, IM, buccal and nasal. Okay, nasal we can give 0.1 to 0.2, same thing. Okay, 1 0.2 0.1 0.2 mg per kg. Okay, but in IV route can give one in 0.05 to 0.2 mg per kg. Okay, in lorazepam can be given IV. Okay, 0.05 into 0 into 0 mg per kg. Okay, and diazepam can be given in two way, IV and the rectal. Okay, rectal can be given in 0.2 0.5 0.1 0.3 ml per mg per kg. Okay, so this is the things we have to know about. Okay, so in this way we have discussed about status epilepticus. We have defined status epilepticus. It will define the seizure continues more than 40 minutes and there is no level of consciousness in between. Okay, you may find etiology. There are CNS infection. In CNS infection, meningitis, encephalitis, and brain intracranial abscess. Okay, then we have electrolyte disturbance. Okay, we have hypercalcemia, hypoglycemia. Okay, then we have hypomagnesemia, hypokalemia, hyponatremia, and then we have other etiologies as well. Okay, in other etiology we can have hepatic encephalopathy. Okay, and we can have drug withdrawal syndrome, drug toxicity. Okay, and other tumor as well. Okay, and then we move further for pathophysiology. In pathophysiology there is disturbance in between, okay, disbalance in between etc and inhibiting neurotransmitter. Then we move further and we have to investigate patient. We investigate child, we do CBC, RFT, LFT. Okay, in serum electrolytes. Okay, in serum electrolyte we look for sodium, potassium, calcium, magnesium, and glucose. Okay, that is glucose emitting through random blood sugar test. Okay, and then we move further and we can do CT scan, MRI. If the also we can do, okay, EEG, ECG. Okay, and we can also do toxicological screening because sometimes drug might cause these things, and then we move for treatment. In treatment we have three things. First thing is sterilization. In sterilization we do ABC. In ABC airway breathing and circulation. Airway we look for airway breathing. We look for breathing circulation. We have to open the cannula. Okay, and then move furthermore, and we have to now treat the patient. Okay, now to treat the cause. Okay, treat the cause. Next one is treat the cause. Okay, in treat the cause we can do, we have first line anti-epileptic drug and second line anti-epileptic drug. In first line anti-epileptic drug we can give benzodiazepine, we have midazolam, diazepam, lorazepam. Okay, and next thing we have that is phenytoin and phospheniton, and lastly we have find etiological factor. Now we have then find etiological factor. We can also give pyridoxine sometime that might also cause the vitamin B6 deficiency, might also cause is status epilepticus. Okay, with this we can discuss on the presentation of status epilepticus. I think we have understood. Hope to meet you soon. Thank you.